So to put somebody off to sleep, the medicines you use, typically you'll come in, you'll put the monitors on, you'll pre-oxygenate them, and you'll get an IV hypnotic like propofol and a muscle relaxant, either Nectine or a longer acting one, and then intubate. Now, throughout the case, maintenance of anesthesia is almost always maintained with inhalational agents, gases from the anesthesia machine, plus minus muscle relaxants if needed. At the end of the case, to wake somebody up, you turn the inhalational agents off, and if there's residual muscle relaxants, they need to be reversed. And so that would be with neostigmine and glycopyrrolate. And then they work by the neostigmine reverses a muscle relaxant but causes bradycardia, so it's almost always added with some glycopyrrolate or atropine so they don't get too bradycardic. And then, of course, as the inhalational agents are breathed off, the patient will wake up. And you guys have all seen that. And so that's just your standard general aspect. Now, if it's a MAC case, you don't have to have a machine. And then, so sedation can be provided with any different types of medicines. Usually it's Versed and fentanyl. If it's a longer case, it's easily done with IV drips of propofol or Precedex. And why we use one over the other, it really doesn't matter. If you're going to give a drip, Precedex and propofol is kind of the same.
Why has Precedex been so much more utilized recently in the last year or so?
I don't know. It's ease of use. I don't know what the cost is. I should. I know the cost of Precedex versus propofol. But both of them work quite well. But they don't cause any, just sedation. There's not problems with one versus the other. Now, the propofol, they don't like using propofol in the ICU because if it's continually used for a day or two or longer, then you can have some issues with propofol. But on a short term, over a couple hours, it'd be fine to use either one.
What kind of issues for the long term use?
Well, you can look it up. You have a propofol infusion syndrome, and they get muscle problems, and those articles are out there.
Michael Jackson syndrome.
Well, you can do that with any. Oh, and then the depth of sedation too. Any of these agents, of course, you can overdose on. So sedation versus deep sedation. You're sedated if they can respond to questions. You ask them, sir, how are you? And if they can respond. If they're no longer responding, you're in deep sedation, and you should really have airway management, a bag and stuff available if you're getting that deep. Any questions then about what kind of questions did you have then?
We talked about preparing for you guys Precedex after extubation. So what should we be anticipating after you remove a breathing tube in the first 5 or so minutes?
Yes, well, you always need to have reintubating equipment available, and you should have some muscle relaxant available if you have laryngospasm. Usually your patients, if they're awake enough, they're not going to have that problem, but they need to be suctioned out and then extubated when there's no more residual muscle relaxant and they're awake enough. Problems you can have, the big one would be laryngospasm, where it's an involuntary contraction of the vocal cords, and then they'll just, they'll turn blue quite quick. And then you'd either hold a pressurized mask over them, and if that didn't break their laryngospasm, then you'd go ahead and administer some succinylcholine, and then you'd have to manage them for a while.
So a lot of the assessments that you guys do over in pre-op, you obviously have them open their mouth, you look at their uvula and the amount of space between their tongue and where you can put the breathing tube. Can you talk about the anatomy, short necks, fat necks?
Sure. Anybody.
When you could recognize someone with a problem, intubation, the jaw, and all that kind of stuff.
Yeah. So when you evaluate somebody, of course, anymore, I can just kind of look at you and tell if it's going to be easy or not. You don't have to get, But if you can open your mouth and you can see the uvula, that's good. The distance between here and your chin, see, I got 4 fingers, that'd be pretty easy to intubate, but if you have 2 or less, then you're going to be real anterior, you're going to be real difficult. The people, of course, with full dentition are going to be harder than edentulous people, and people can't open their mouth at all, and that's what you're looking for. So The main thing would be the distance between here and there. If it's really short, you know they're going to be real anterior, and then you'd want to have your glide scope and other equipment. And then, and of course, the biggest thing as far as difficult intubation, the biggest sign is if they've been a difficult intubation before. And then the distance, and then if they can open your mouth. But all those are things that we evaluate everyone on.
Just a reminder on your handles. So if it's in a bag, what does this mean?
Clean.
It's clean. So every time anesthesia comes into the room and they remove this, what do we do with the Ziploc? Just save it. After we use it, so they're intubating, they put it back on their ventilator or their anesthesia cart. What do we do at the end of the case?
Clean it.
And then what do we do with it?
Put it back in the bag.
Okay, so in between cases, if Jacob comes in, it's in between cases. It should be found like this, right? So that's bags are in the anesthesia carts, unless you throw them away.
Yeah, they got thrown away yesterday. After every case, I'm like, where are my bags? They're gone.
Okay, so go. Teresa has a whole stash of bags. She went into each room this morning and replaced all the bags that were gone from yesterday. So make sure you don't throw those bags away. Keep them. Identify. Make sure you're wiping the blades down in between. Have a discussion with your provider in your room, your anesthesiologist, your CRNA, which we need to talk about CRNA and anesthesia.
Okay.
Just talk about the role of the CRNA and then why he or she can't intubate. It's because of our policies here with MCA.
Right.
Just kind of talk about that.
Okay, so, of course, we hire CRNAs, and we're gonna have more, I'm sure, from into the future. The departmental policy, which isn't even an well, it's the department within the hospital's policy, is they are to be supervised by us. So we're there at critical points during the case, the beginning of the case, basically, and interoperatively check on them. But yeah, we, our nurses do not initiate and start general anesthesia without us present. And so when they're there and ready, one of the attendings will have to be called. But that's not the same in every hospital, because CRNAs obviously have...
Surgery centers and
Yeah. Any small hospital is not going to have an anesthesia doctor, and so the nurses can function on their own, and they'd be capable to do that. But the reason we're coming at the start is because of departmental policy.
Biting of tongues, and do you have, talk about maintaining an airway, some of the tools that you can
masking somebody?
use, nasal trumpets,
Yeah.
etc.
Yeah, masking is a skill that not everyone has, but you gotta be able to do it. It's more important than being able to intubate somebody. I typically just use a Berman airway. So to safely induce somebody, you'll push drugs and they'll go apneic, and then you can mask them. And if you can mask them, then you'll push the muscle relaxant. Now, if you put somebody to sleep and you can't mask them at all, then you shouldn't be pushing muscle relaxant, because then you still probably won't be able to mask them all, and then becomes an emergency then. So if you can mask them okay, then you push muscle relaxant. To assist in mask ventilation, you can use either nasal trumpet or Berman, and I prefer to put in an oral airway, and of course that just takes it out of the way. And to mask somebody...
So the Burmas are the little clear white things that you put down.
The curved, and then to mask somebody, of course, you just don't smash the mask down as hard as you can. The key is to get your finger underneath the corner of the mandible and pull everything up while holding, a seal of your mask and up. And of course, intubating position is the sniffing position. That's anesthesia 101. So when people come in and you want to get the head propped up so it's a straight shot from here down to your trachea. And so when you see people that come in and the first thing they do is pull all the pillows out and they drop the head clear back, they don't know how to intubate people. And so at the end of the case, you have to be careful that people aren't biting on their tongue when you go to extubate them, or biting on the tube. But usually that's not an issue. Corneal abrasions is another thing we should probably talk about, because it's quite common, and it's not necessarily an abrasion. It's more common to have corneal desiccation, and that's where people have all the eye pain after this. So it's not physically getting something rubbed in the eye, it's the eyelid staying open, the cornea getting dried out. So that's why typically most of us tape. If it's a longer case, you'll lube and tape. But that's how we prevent those. Yeah, so if you see somebody asleep and their eyes aren't taped, they probably should be. And then dental work, who knows how many teeth we've chipped out trying to intubate people. It's a big insurance thing for us. We paid for a lot of teeth over the years.
Do you want to talk about rescue anesthesia? So if a patient was under our care as an elective case, such as conscious sedation, and we get them too deep, and we call for you guys to help us, kind of talk about why your license.
Well, yeah, obviously we're not liable until we're there. But then once we've admitted and they're there, then of course then we're liable for that. So, but what you'd want in a situation like that is just all of the standard airway equipment. You need to have stuff to intubate, mask, airways, suction, just all your standard setup, just like a general case. In fact, anytime sedation is provided anywhere, there ought to be standard airway, ambu bag, suction, intubating equipment available. And yeah, we wouldn't be liable until we actually got there, and then our liability would start at that point. So, I mean, just because you call somebody, that doesn't, we'd be liable when we got there. But do you ever have problems getting it? Well, you don't really have problems.
I can never get a crowd like this, man.
Yeah, I know. We're talking, anesthesia's so exciting.
Yeah.
Oh, God.
Being a Tom Ford.
I should have a suit on. And an AV presentation. So, do you have any problems getting us over here? You never run across that anymore.
No, we talk about the assault, because typically we have you, but we talked about before the assault, because once we don't consent for anesthesia prior to, so if we would call you for help, typically if they're not able to give us informed consent.
Right.
And so it's called assault for an anesthesiologist to intubate a patient, unless it's an emergency. So if we're for elective cases, what should we be doing to that patient before taking him down to a general? You reverse them from the conscious sedation, so you reverse them from the Versed and fentanyl and wake them up, and then you would give them an opportunity to be informed of the consent that they're going to give you or talk to their family. So you should bring them, elective. Emergency, we would do it. But if it's not an emergency case, doesn't have to be done today, you would reverse them, wake them up, and then bring them back another time for the next state or next part of their procedure to be done. So you wouldn't put them into a general anesthesia if it was not an emergency. You should always reverse them and bring them back to their state of consciousness instead of putting them into a general. Do you want to talk about Narcan administration?
Well, certainly, Narcan's just a narcotic reversal agent, and it comes in a 0.4 milligram vial, and I never start with a whole vial. You start with just a very small amount, because if you give too much too rapidly, not will it reverse all the narcs, and they'll have discomfort if they're having a procedure like that. It can also cause like flash pulmonary edema and things. So you just be very gentle with it, and it just displaces the narcotic off the receptor, and it typically does not take much.
How much did you start with?
Well, if you
Like
come with a
0.2?
1 cc vial, I start with a fourth of that. So if it's 0.4, you can never give more than 0.1 at start. Yes.
I'm interested in what Andy just said about we reverse them and then we get a signature. Like, so what's the time limit on that?
Well, I
Because
think,
that's
I mean, she's talking about bringing back another day.
Okay, so like,
something.
this is, so
If
clearly
you
this
just
is not
kind of-
anything that's gonna be done during that procedure.
Yeah, and
Okay,
that
I
would
just
be an
wanna make sure
emergency, and then you just kind of
Do it.
You just do it.
This was before we had anesthesia tied to our cases. There was a request why wouldn't anesthesia provide support. That was because we had already sedated them. We brought them down to conscious sedation, and then we needed them deeper. The doctors would say, "Yep, we need them deeper. Call anesthesia to put them in a general." Well, that's assault because the patient didn't give you consent to give them a general anesthesia before they were induced.
No, I understand that. So basically we're saying we would stop the procedure.
Yeah.
And then, okay. I just
It
wanted
really
to-
doesn't happen here anymore.
No. we're involved in so many cases, everyone would be consented for whatever.
So if we were doing it the next day, we wouldn't necessarily reverse them, we'd allow them to recover.
Mm-hmm.
Okay.
Yep. There's been some concerns over in cath lab recovery recently where it's been a surgery consult in the room, and then we go to cath lab recovery. They talk to the surgeons, and then they give consent for the next day.
Mm.
We need to be really cautious with getting consents when the patient's had anesthesia on board or Versed and fentanyl. There's been a couple instances. Where's Jen?
Me?
Jen Ludwig?
No. Where are you?
Okay, so we had a couple incidences last week. Do you want to talk about that with Dr. Hoffman? And how was it taken? I mean, it was.
He actually did really well.
Yeah.
'Cause I was like, ooh. No, he was consenting for a surgery coming up in March or April.
Right.
So nothing the next day, and he had her sign it. She was still kind of groggy anyway, besides the fact that she had her sedation. But I just said, do you think maybe your husband should co-sign that consent? Oh, good idea.
Yep.
Because they do it. All.
Yep. So we just be cognitive of that and aware when our patients are sedated, when they are making sure that they're fully competent to sign their consents. So, yeah, Taryn.
Dr. Hart, can
Yes.
you talk about a little bit about emergency drugs with patients under anesthesia that have cardiac issues, like specific to people?
Aortic valve.
Aortic valve, EP related. I mean, you know,
I mean,
a lot
if you're
of-
gonna have a code status, it'd be just, your standard emergency drugs, your standard red box drugs.
So there's never meds that you'd like to avoid with people in the cath lab based on what
Oh,
they've had
things
for
that
like
you wanna
ablation
avoid.
or aortic stenosis or.
Well, yeah, aortic stenosis is more of a filling condition.
Okay.
Aortic stenosis, you want hearts to be slow and full and the pressure high, so you don't have ischemia. Yeah, we not that long ago had an aortic stenosis in the OR code, and you can't let the pressure drift too much because the ventricles are enlarged. It takes more pressure to perfuse the myocardium, and it's a tight ventricle, tight stenosis. So as they're under general anesthesia, it's pretty easy to let them kind of drift down. And the problem is then that you don't have enough blood pressure to perfuse the myocardium. And so aortic stenosis, you want the heart rate to be slow, it decreases oxygen utilization. You want the pressure to be high so there's myocardial perfusion pressure. And you want sinus rhythm also. So you'd avoid things that sped the heart up, and you don't want to cause any ventricular arrhythmias placing PA catheters if you have tight aortic stenosis. So you'd avoid hypotension and hypovolemia.
And are you more selective about the agents that you select to raise pressure?
Oh, for aortic stenosis, yes, it'd be better to use phenylephrine than ephedrine because you don't want increased heart rate. Yes.
Are there other procedures in the cath lab that you are mindful of drugs? Like, I don't know about EP procedures. I don't know. I mean, I don't know if there are.
Weight-based history of.
Well, aortic stenosis is an excellent, but, AFib too, you don't want anything that's going to increase the heart rate too much. So again, you wouldn't use ephedrine or epi.
We've had a couple family members, patients that have had family members with northern hypothermia and
Okay.
with anesthesia, maybe that's why.
So with
family history versus, or known history versus acute onset, or, oh crap.
yeah.
What do you want from us in the EP lab or the rest of the lab?
Well,
initially?
if somebody's actually having a case of
Hemorrhage
malignant
crisis.
hypothermia, then you need to have dantrolene available.
Correct.
And
Which is located where?
In the cart, in the OR.
Where at in the
Against
OR?
the wall,
Where at in the OR?
halfway down the hall.
By between, right outside room 1, OR 1, MH cart. Okay.
And so that's administered 1 milligram But you'd immediately stop all your inhalational inductions and start cooling the patient if they're already cold. You'd hyperventilate them with 100% oxygen and administer dantrolene. Now, if it's a known or not, almost all
history.
these things, history, you know them
History,
before.
yeah.
So then you would avoid, I mean, you can still provide a general anesthetic, obviously, but you're not going to use an inhalational agent, you're not going to use sevoflurane, desflurane, or isoflurane, you're not going to use a nectine. You can use muscle laxants that have to be Zemuron or Pavulon. And then you'd run propofol.
So we
Or-
flush our machines prior, and then
Yeah.
typically you put tape over all your inhalations so that
And we
no
also have
one.
those filters.
Yeah.
So you can use the anesthesia machine, you have to have them flushed and or put the filter on them, and you should probably just take the vaporizers off. Now you can use nitrous. So you could run an oxygen nitrous combination with an IV agent, usually Diprovan. But you could use Precedex, you could use Versed. There's a lot of different agents you can use. But the agents you'd have to avoid would be the inhalational agents and a nectine, the succinylcholine.
What are the first things that you recognize if a patient is having MH crisis?
Increased end-tidal CO2,
Okay.
tachycardia.
The actual hypothermia is considered kind of late in that
Late,
situation,
yeah.
correct?
So the first thing would be hypercarbia, tachycardia, and then the
Temperature.
temperature would go up eventually. Dantrolene's been administered a few times, not that long ago.
Ooh, I have a good one.
Yes.
We'll determine that.
Well, we would like standing orders for ABGs with lights. What you guys want in an emergency, because we've had a couple of perfs that we've had to go from MAC to general, and then you guys have a certain request of labs,
Yeah.
and then we have to call Janet, and like usually what happens is we end up calling somebody that's not involved in the case, like your charge, and asking them what you guys want.
What
with it.
can you get on your iStat?
Not the right stuff, evidently. That's what we
Really?
found out.
It's just the
Black
ABGs.
case.
You don't get an H&H or like.
Oh, well, if there's
Perfusion can do it, but.
yeah, if there was anything where if there's a perforation, if there's a blood loss, we'd want the ability to get a hematocrit.
Yeah.
Well, sometimes, I mean, I know in emergencies, I don't know about EP, but like I've been in some ECMO cases or some things that have turned in and we just run it across over to, somebody
Okay.
just grabs a sample and goes to OR
Yeah.
to use their machine.
But a lot of times.
But they have to be there, because we don't always have perfusion there, like,
we were just hoping for
in
standing
your
orders so we
situation,
don't
like
have
if
to
you
keep
perf or
doing
something,
that.
perfusion's likely
Because we've
not
had like
there
a rash
yet.
of like 3 probably in 6 months, so then it seems
So
like
they're
we
not
need to
just in,
up our game.
the OR?
Respiratory.
oh, I had an OR nurse go with me.
Or if we
Once.
just
I thought they were just, that's what their machines were.
Respiratory.
Sounds like
Perfusion's
respiratory.
in the OR,
Yeah.
Call
but
respiratory.
they're not always over here, is what I'm saying.
You have to tell them.
But they wanna order, they want you to order H&H to that.
Yes.
So that's
So
what
So
she's trying to
shouldn't that
avoid.
just be like standing orders on a MAC case, like having that information anyway?
I think that's what she's wanting.
I don't know if I've ever
We don't have
ordered
it in
gas
order.
and not wanted to know what the hematocrit was. So how come we have a machine that
Our,
we can get?
our machines don't do it, we have to have a different cartridge, and the machine's set up differently to be able to do that, because I asked about it. So we can run gases and we can run ACTs, we have cartridges for that, stuff in the liquid lactate, but that's all we can run off of our
Yeah.
machines.
Oh.
So it's a whole different.
What I'm hearing is a blood gas, syringe, and respiratory, and making sure when respiratory comes and picks up the blood sample, you tell them you need H&H and lights.
Is it a
And you
big
put the
deal
order
to
in
be
for
able to switch it so we can run that stuff?
I mean, because anytime we put someone on ECMO, we're
I
going to
asked
need it.
about it,
But
Anytime-
perfusion's there, so they have their machine.
Not initially.
Not with us.
Yeah, you
No.
have to ask them.
Heather's the only one, well, I don't want to speak for Minnie or Scott, but Heather was the only one that was able to dig it out with her experience on the floor and something about her access, so I don't know.
For what?
When we've had to call for, and like actually put the orders in, because the last time they just stood there and looked at us and asked us.
But it's not, I asked about it.
Respiratory
I still
did?
have the email.
Anesthesia asked for them immediately, and there was no perfusion involved, and then, like 5 or 10 minutes into it, they were still asking for an order, and so it was like this back and forth game where it was already being held in someone's hand, and it was like, just get it taken care of. So then we had to rely on, like, charge to handle it, and it was just like.
All right, Heidi can work on that today,
Yeah, maybe
she's in
it's-
charge.
Thank
Well, the standing order,
Stepping up. It's just annoying.
the standing order
It's,
should
we just need to
be,
figure out what the order is, the correct order is. Put it in.
Yeah,
should be a gases
Oh,
with
RT
an
lunch,
H&H.
yeah. We ordered those all the
Does,
time.
does your machine
Yeah.
get the glucose and lactate or just lactate?
Just
lactate.
Okay.
We have a glucometer separate. We have three:
That's how you're.
glucometer,
supposed to
ACT,
order 'em, period.
ABG.
Well, the glucose probably wouldn't be as important as just getting your blood gas and your lactate and your H&H, but that should be standing order probably. If we need an emergent blood gas, H&H should be part of it.
How about, pre, and I know that a lot of it doesn't affect people here, but it does, x-rays,
Yeah.
so, which, like Down
Well,
syndrome.
right,
Flexion
rheumatoid
extensions.
arthritis. Yeah.
And then, so,
Alright.
because we pick up patients and sometimes I know that out west, we had a patient that we had to take 2 x-ray prior.
Right.
Because they didn't have them, and so I think it's things to think about. And then, your standing orders for an H&H is how many days prior, and then, for potassium and your H&H.
Well, I think the potassium is pretty short, but H&H is like a couple weeks.
Yeah,
H&H I think is 14 days.
Yeah. But
And if they're on dialysis, it needs to be within a couple days.
yeah.
Within what?
So, and then things like if they're on, Lasix, you know, the potassium
One.
versus, I guess,
Day of.
can you just talk about that, because we pick up patients and there's a few people from recovery, and just so everybody's on the same page on that stuff, I
Well,
guess.
the potassium, if they're on a diuretics, is you need a more recent K than 2 weeks, I think.
Right.
Or usually it's done the same day.
Right,
But I don't know what the outer limits of that is. Well, I don't know, a couple days
I would say day of, you'd want it if they're on dialysis, or
or on
day of,
diuretic.
within 24 hours.
Well,
we
yeah,
draw
I mean,
potassium on everybody out west.
yeah.
Why is it important when you put someone to sleep to know what the potassium is?
Well, you don't want it to be too high, obviously.
Why? What does
Well,
it do?
because, well, you can have ventricular arrhythmias. And, we just had that, you get peaked. On your EKG, if you have really peaked T waves, then that's a bad sign, you ought to be checking a K. 'Cause, I had a potassium of 7 in the heart room just a couple weeks ago. So to treat your hyperkalemia in that situation, first thing you'd do is you'd give some Lasix, and then you'd start an insulin and glucose drip. Those would be the 2 things, and you could hyperventilate, and then if you have peak T waves and it's starting to throw arrhythmias, then you'd push some IV calcium. So, and then you'd have to get them dialyzed. So, Lasix, insulin, glucose, and then calcium, and hyperventilate to treat your hyperkalemia. You can also start some low-dose ionotrope like epinephrine, and that tends to drive the potassium into the cells.
So, can I go back to that dialysis day of, because that's bit us in the butt a couple times over there already. Are there other conditions that you want labs more than 14 days, within 14 days, other than dialysis, that we should be aware of?
Well, I mean, obviously, if there's an acute change in the patient.
Okay,
I
but
mean,
there's not like a protocol,
No.
that OR follows of
No.
certain things, okay? And then back to the whole RA and Downs with the C-spines?
Yes. Well,
Do you-
the films, I think, it's within a year, I think. And a lot of times.
Okay, we wouldn't know if they have one.
It's kind of, at the physician's discretion. I mean, the little kids with Downs, I almost never get films.
Okay.
I mean, if they're older, usually they have them. And again, unless there's an acute change, if they're over a year old and they've had them before, the films are over a year old, I don't mind, I don't make them repeat them. But, and I don't know the exact date of the protocol on kids with Downs when they're supposed to get flexion extension. When they're really small, to me, it doesn't make any sense, because how do you get a flexion extension on a tiny little kid anyway?
And it
then
doesn't matter, obviously with general, but even with MAC, you would want these C-spine x-rays?
that would be at the discretion, but I think it's
Okay.
protocol to have them done.
Okay.
And then the adults with, they're, I think, supposed to have them within a year with bad rheumatoid arthritis.
Can you talk about the use of, I'm probably gonna mispronounce it, Sugatimex?
Sugamidex, yeah.
Yeah.
CHI doesn't want us to use that because it's really expensive.
We've used it a few times.
Yes.
Yesterday.
And you know why it's really
We do
expensive?
have it.
Because it's new and it's good. No, it's a wonderful drug. So, when you're reversing Zemuron or Pavulon, longer-acting muscle relaxants, and when this tends to be bad is in old people, because old people do not, it sticks around a lot longer. So neostigmine and glycopyrrolate would be your standard reversal agents, but they can only reverse so much, and it takes 10 to 12 minutes to get full effect from neostigmine. Now, Sugamidex can take somebody from very deeply paralyzed to total reversal of paralytics with just a few minutes. And it doesn't cause the bradycardia that you get with neostigmine, so you don't have to add atropine or glycopyrrolate to it. And so it's a lot more potent with a lot less side effects, and it works really well, and it's a great drug. But CHI doesn't want us to use it because it's expensive.
We have it in our antidotes, FYI.
Yeah.
200 and 500.
And it's I've
But we
used it a
can't
few
have-
times, and it helps
That's right.
on old people especially, because old people, you just give them a little bit of muscle relaxant, and it sticks around a long time.
Can you talk about ketamine?
Ketamine, oh, special K. Well, ketamine is a wonderful drug because you don't really typically kill people with it. You can give a lot of ketamine and they will continue to breathe. It causes side effects, so they have a lot of drooling, and then but the major side effect would be they have bad hallucinations. So if you add a baseline, a little bit of midazolam, a little bit of Versed, then the hallucinations aren't as bad. But ketamine's excellent in the fact that people can be catatonic and they get nystagmus and their eyes will be flashing back and forth like this. But you can just, like little kids, if you give them enough ketamine, you can just hold onto their hand and put an IV in, and they're just kind of drooling and they're totally dissociated. And it's a wonderful drug for particular situations, and also it works IM. So you can take an adult, and if they're very combative, you can take 5 milligrams per kilo and just do an IM stick, a ketamine dart, and they will go down. And so that works very well that way also. Ketamine's not typically used in your normal adult because of the hallucinations. But I did use it in the recovery room to do a case on a young gentleman with pulmonary hypertension because this cute little pulmonary doctor told me she thought it'd be a good idea. And of course, I didn't. And then her mother the mother of this child was convinced that he needed ketamine too, and I said, well, yeah, I can give it. He'll have bad hallucinations, and I went on to explain this, and then her mom just kind of, but we used it and it worked fine.
Excellent.
Are we allowed to push ketamine as nurses
That's
if
what
they
I
have
was-
an airway?
I want to clarify, and we've all talked about
We
this.
talked about this the other day.
What about
Why couldn't you?
What about our our sucks and rock and ketamine and those types of things that?
Yeah.
And I don't know if this is a question for you or more for rapid response when we come to rapidly intubate patients and we get asked to pull up these, etomidate.
Right.
What we are allowed to push, and I'm not convinced that all of our nurses in the lab not against anybody, know the dosages for that, and we need to be better educated on.
Yeah, we had an instance the other day that the patient did everything, went to ECMO and took the patient to the OR, and anesthesia came over, but then left, and the patient was moving, and we had drugs pulled, and we were a little uncertain. They had told us
But
what
they
to
were
pull.
intubated.
They were intubated, but we were a little uncertain.
We don't have the anesthesiologist in the room either.
Right, we just
left.
didn't know what we were supposed to be
Sometimes
doing.
rapid response is
I've
like,
been
pull me up some sucks, and you're, okay, how much do what are the dosages for
And
that? Or I've been in a case with Chava where, propofol is dropping our pressure and we have an airway, and he's like, you need to just push some sucks or some rock or something so we can, it was emergency, we just need to get this done. And, I feel like our nurses need to be better
obviously,
educated on what
I mean,
doses are safe.
The other scenario is post-intubation, they're starting to wake back up, we're getting out of the lab, we're getting back upstairs, we need them, so that's where I've been asked is, we need them paralyzed a little longer,
Yeah.
so we can get upstairs, so
Right.
propofol can, start to work, and so I phoned a friend in Mercy One to say, what are the normal doses, because
Well,
something
intubating
totally
dose of Zemuron would be like 0.2 per kilo. of Zemuron. So, I mean, typically an adult, it's 0.2 to 0.5, but you can give more. But in a typical adult, 70-kilo person, you can give 40.
So outside of the specific doses, what drugs are we or are we not allowed to? I think is the question I'm hearing.
Well, I mean, is there anyone on Rapid Response that has a different license than our nurses in the lab?
No.
Okay.
Who's
It's a matter of
doing it?
education, and we've been told by
No, we can't push them.
that we can't push them because it's not within our license. Like IV ketamine, we can't do it. We're not allowed.
But why? They have an airway. Like,
Ask Mercy.
I didn't
It's a
know that
mercy
we were on
It's
protocol.
a mercy
push
thing.
ketamine.
I don't know.
We can't. We've never been
That's a
even under
policy
the
somewhere?
even with the doctor in the room.
Yeah.
We've not been able to get
We
ketamine.
were able to push ketamine IM,
Yes,
but
Do I
not
am,
IV.
can't do
It's a
IV.
big no-no.
So,
And
I
they
mean,
can't
what
do
I'm
it on the
saying,
floor
what I'm
either?
saying is, if this is being allowed, everybody needs to know this, and everybody needs education on it. But in the past, we could not do those kind of meds. They're
I think
things that
that's
we don't
something
even
we
get for
definitely
our
need to look into. what
education.
Mercy's parameters are, I guess, for us.
We definitely do, because in PICU I could push ketamine, but I had to be doctor supervision right there with me. But I could push it, like I legally could do it, so.
I think legally what we're allowed to do and what Mercy policy allows are not exactly the same thing.
Who's pushing the medications if someone comes into rapid response team to intubate somebody? Who's actually
They are.
pushing those?
Whoever comes
Or
up
us.
with
I mean,
it.
I
I've
do.
done it for them, but they've
I
told
used to
me,
do it in
they've
the
drawn it up
unit.
and
Yeah.
just given me,
Just
they
tell
told me
me
exactly what to
Right.
give.
Yeah, same.
So I guess I don't know why you couldn't
I don't
push
know.
ketamine. But
I think
they'd be
people do it
interesting things
because
to know
we
from a
are
departmental
not
level
supposed to
what
push all
exactly
that
is
stuff,
being
and then it's like
administered.
hearsay, what we are or are supposed to
If a
do.
physician's telling me to push it, I'm pushing it under his discretion.
Right.
I would never pull up rocuronium or succinylcholine and give it. I would verify it with a medical physician
And our docs
and my
don't know the
dosage.
dosage.
That's the thing, is our doctors know what they want, but they don't know the dosages, they rely on us to know that with our education.
I would say within your
We need some more
ACLS guidance,
education.
if anything is taught in ACLS,
None
I
of
would.
that.
No, none of that.
Okay, so then we need further education
That is
if that's what we're going to
Yeah,
do.
sucks and rock or not.
They have emergency med sheets that can be printed out online that will go, like for kids under 50 kilos, there's a weight base, and then there's if you're 50 kilos and above, so adults. They have, it tells you, so based on this 50 kilo limit, you would push this much of this medication. And so all you have to do is just go, whoop, I want this med, go straight over, I give this much, it gives you mils and dose, so you know
Do
exactly
you want to work
what
on
to push.
that with Kayla?
Use that in your career.
But there should be additional training though. I mean, you have to understand the significance of what you're giving and the side effects, like not the side effects.
You're not giving it by yourself.
Right,
No,
you're
you
doing it with a
have to
physician, the
understand
physician's
it.
giving
As
it.
a provider, if
Saying
you are the one
give this.
administering the drug, you should be.
You
able
are
to-
under the
are-
doctor every
You
time
are a
they tell
nurse.
have them
You
do
are
it.
You're
not.
still responsible for your own behavior.
Well, no, but
No,
the
because
nurses.
it's under your physician's license. The
No,
physician's
I agree
telling
though,
you.
but you can't push anything that you don't know what you're
Exactly,
pushing.
you should
If
Right.
you don't know
It's
your
a drug
action,
to
how to,
patient,
you
that's
know,
not
what to
what
do,
you want.
what it's gonna do, your side effects, how it acts, then you shouldn't push it.
Right.
I mean, it's
That's
fine.
fine.
And
nothing against Kayla, but I kind of feel like this might be out of her scope.
Then, and
She's
doesn't
not
know
a
what
nurse,
she wants.
so I don't really
He's
feel
really
like that
need to
should be
know.
Kayla's
Right.
I mean, it's kind of a
responsibility.
fine line.
It is his order, it is
Right.
under his license, but
Correct.
he's depending on me to
To know what to give.
to be able to help clarify those dosages, so.
I have a
I had
question.
several
Yes.
people look through that though, so
Not
that
necessarily
wasn't
for
just
you,
my
but for-
Yes.
it's about
So,
SIBO.
but
Yeah.
you're saying that in a very derogatory way, and it's,
No, I mean, but that was like it was huge.
Hey Angie,
It's and it's fixed.
I have a question about sevoflurane. When they're out of it, they need another can of it or whatever. I've been told two different things. One, go charge it to the patient across the hall, or there's an anesthesia.
Cath lab
Patient.
recovery and AccuDose, you can charge it to the department or to the patient. The patient won't get charged for the whole bottle.
Oh, okay, that's what I was wondering, okay. Because I've been told two different ways, so, okay.
Cath lab recovery is like one of the options. It's a
Oh,
departmental
as a
charge. I would just
Why
charge
do we
it
keep it over there and not over here
because
somewhere?
there's no room in our AccuDoses.
Okay.
And it has to be locked.
Even in theirs?
Too much
Even in theirs? It's-
That I don't know. We lost a lot of stock in the anesthesia carts when we went to Pyxis.
A lot of space.
Lot of
Yeah, in
space.
your pictures.
Usually it's in the bottom drawer of them.
So that was a very confusing.
But how many are in there usually? If it's full.
Sometimes not.
That should be one of the things that
We
they
might
check
ask
in the
us to
morning.
go get it over there, they probably use it up and it just.
Yep.
Okay, okay.
That was a very bad.
And then, like, is there gonna be somebody to take charge of? Cause, you know, Jen's right, if Kayla isn't comfortable doing all of that med stuff, then somebody needs to take charge. I mean, Kayla has done really awesome things with our books.
Sheets are amazing.
Yep.
And they're great, but.
We'll work with pharmacy.
But I
It'll be
feel
a
like, what I'm saying, I
multidisciplinary
feel like
approach.
it's every nurse's responsibility in this room to educate themselves. I mean, I've gone home and studied what I need to know
To take care of your
safely take care of my patients. But I'm not sure that that's coming through on it, you know, I'm not picking people
You're
out,
not
but
pointing fingers,
I
but
think people are, you know, we think about it and we're like, oh, we need to look that up later, and then sometimes you don't, and then we're in our next situation where we're like, what are the dosages on that? We don't know. So
Autumn's gonna work on it.
Yep.
yeah. So I think
You can make
and I'm
her
trying
do
to,
it, and she can
I don't know
use Kayla as
everything.
her reference on
I'm
how
happy to
she
help
wants
too.
to do something, but she could do that, yeah, and use Kayla as her reference on how to go about doing the information, and
But like Ann said, I think every nurse in this room needs to look up all those meds and be very comfortable with what they do.
But we also need to know what Mercy's policy
Yes,
is,
we
because
need to
it
look that up.
has
Absolutely,
changed
yes.
over the years several times, so we also wanna be in.
And some of those questions I've asked, because they were different for me when I came here, and I've gotten different answers. So some of it's still not.
Changed over the years.
Right, and yeah, nothing, I mean, just, as things evolve.
And we just keep doing what we've done.
Yep.
Yes, so that's,
And I've been told I couldn't push certain things here that I could push upstairs, and like, what can I and
Yeah,
not?
we just need to clarify.
And if you're pushing them upstairs.
Well, I feel like that's an easy fix. I mean, Mercy obviously has policies.
Yeah, we're just saying
Very easy
somebody
to look it up.
Who is the
I
person
also
that we
feel like
talk
it's
to
an
about
easy
drugs
fix
that
to
we
get
can and
educated
can't? Who
on
tells us what we
dosages
can
of
and
these
can't
meds.
do?
I mean,
We'll
we
talk to
have
pharmacy.
resources.
Okay,
Yeah,
We're gonna work on all this stuff.
that's great. That's so great.
I think just the point of that conversation was getting everybody on the same page to do it.
See, and the same thing goes, and is for our, prophylaxis thing. Some people are still saying 40 of Decadron. Our policy says 20. No, but it's 40. We've always given 40. And so,
We need to go by what our policy is.
So,
okay, but.
Or
Not
we
the
need to
doctor's
change it through our medical director.
Yeah, but, yeah.
so the doctors are telling us they want 40 of.
That's not our policy. So we need to go by what our policy says until we change our policy.
So we have a
So then we need
formal
to speak with
prophylaxis
Dolly.
policy, because I've just given physician ordered meds.
We have our protocol.
I
If the
was
doctor
unaware.
says, we give our protocol, unless the doctor would say, no, I want 40, so you're not doing our protocol, you want to give an additional 20.
Okay,
If the doctor says they want additional, I mean, they're in charge.
sure,
But
certainly.
if they just say do the prophylactics, I would do whatever our contrast allergy prophylactic says. And it's different the day before than the morning of.
Okay, so I can tell you too that.
And
our
Shiverport
doctors
is
are-
different. Shiverport is different on contrast allergy, so
So I
if he wants something different, just do what he says. If
But
it's just
he's
saying
not
the
only
protocol.
one, because like Chabla the other day, I said, what should I give? I said, do you want 20 or 40? He goes, I want 40. So they're assuming that we're giving 40, even though.
So
the
then they
protocol's
don't know what
20.
our policy
That's
is. So
correct.
I would just say, I'm doing the policy, I'm giving this, this, and this. And that would give them the opportunity to say, no, I want 40. If they constantly want 40, then we need to look at the policy and change the policy.
Okay, then Kayla, guess what we need to do?
We'll bring it to the IB meeting. Kayla's
Please
not
do.
doing it. We'll bring it to the IB meeting.
We haven't, we changed it yesterday because of a different number, but, changed it to 40 because that's what our doctors are asking for.
Okay, well, that's not our policy, so we need to take it back to the interventional meeting and talk to them about it.
Yeah.
Right, that's what we have to look at.
All right, does anybody have any more questions for Dr. Hart?
Very nice job today.
All right.
Thank you.
Thanks, Dr. Hart.
That was fantastic.
Yes, sir.